Hello everyone, my name is Kathleen Keegan-Pursell, and I'm going to talk to you about COVID-19 and the exacerbation of racial health disparities. COVID-19 has essentially shed a light on the disparities of this population when it comes to their health care. As you can see from the above image, Blacks and Latinos are at greatest risk from COVID-19, as well as many other issues. The United States has had a long history of racial and socioeconomic disparities. The current COVID-19 pandemic has further revealed the rifts created by historical injustice, structural racism, and interpersonal bias. The underlying health disparities of this population are complex and include social and structural determinants of health, racism, and discrimination, as well as economic and educational disadvantages, healthcare access and quality, individual behavior, and biology. So if we were to list some of the most common disparities of the Black and Latino population before the pandemic and now, what would you come up with? Would you be able to name them all? History shows that severe illness and death rates tend to be higher for racial and ethnic minority populations during public health emergencies than for other populations. The rate per 100,000 of the population is shown on this graph. This is astonishing compared to the white population. Let's talk about pre-existing conditions for these populations. So what are the health issues that make this population vulnerable during these times? Well, there are many. We will talk about long existing disparities of this population and some that relate to the pandemic. The first one is uninsured or underinsured. In 2018, 26.7% of Hispanics, 15.2% of non-Hispanic Blacks, 9% of non-Hispanic whites lacked health insurance coverage. This most oftentimes leads to inconsistent access to healthcare, especially those with chronic diseases. For example, a person with diabetes and asthma with inconsistent absent treatment is at extreme risk for a severe, even deadly coronavirus infection. While all racial and ethnic groups had large gains in healthcare coverage under the ACA, Blacks and Latinos remain more likely to be uninsured compared to whites. The second is language barriers. In both the Black and Latino communities, there are different languages depending on the area of the country you're addressing. In Northeast Pennsylvania, we have a large population of Spanish-speaking citizens. If persons can't speak the language, how do we know they are getting the proper messaging related to COVID-19 precautions, or where to get tested, or how to access healthcare for other issues? Mistrust of the healthcare system. The Black community has had a history of mistrust of medicine since the 1918 flu pandemic, and then later with experiments that were done unknowingly on Black men and women. Blacks have the greatest general mistrust of medical professionals. It is widely known that many do not feel they get equal treatment in healthcare systems. Immigration status. Persons who are not legal here have fear of going to get medical treatment. Immigration has been in the spotlight over the past 4 years, and now more than ever they have fear of being sent back to the country of their origin. They also work under the table most of the time and can't stay home and quarantine. Financial and essential workers. The photo you see is taken from a video that was done by Bloomberg on the outrage that came at the beginning of the pandemic from essential workers. Lower wage workers were not being protected on the job and yet were considered essential. From this protesting came change. Communities of color face increased financial and health risks associated with COVID-19 due to the economic and social circumstances. Blacks and Latinos often have jobs that pay poorly, are not afforded the ability to work from home or take vacation days for furlough or quarantine appropriately because of living conditions in urban areas. Social distancing policies required for safety during the pandemic have led many businesses to cut hours, cease operations, and close altogether. People who work in certain industries such as restaurant, hospitality, retail, and other service industries are particularly at risk for loss of income. Many persons of color are considered essential workers such as grocery store workers, delivery drivers, and are at an increased risk of contracting coronavirus since they remain exposed to other individuals. Nearly a quarter of Blacks and Hispanics, 24%, are employed in service industries compared to 16% of whites, putting them at increased risk for job loss or loss of income or for exposure if they maintain their jobs. Living conditions and multiple people in a small household. Persons of color can have more crowded living conditions, which can make it hard to quarantine and quickly spread the virus. They have limited access to fresh foods, less likely to be able to access green spaces and fresh air. These groups are more exposed to environmental hazards. Lack of education or lack of quality education. Many have not had the best education in inner city schools or dropped out of school. Some have disabilities that were never addressed. This can make it hard for them to fully understand COVID-19. Pollution. These groups are more exposed to environmental hazards and unsafe working conditions. There is also a higher concentration of respiratory hazards and toxic sites located in low socioeconomic, minority-heavy areas. The health issues. The Centers for Disease Control and Prevention state severe illness and death rates for these populations are higher during public health emergencies compared to other ethnic groups. This pandemic has only made the aforementioned disparities and the structural discrimination they are rooted in more apparent. People of color are more likely to be infected with COVID-19 and more likely to die. Many assume the health issues that are predominant in the Black and Latino community are mostly related to genetics. Yes, genetics do play a part in disease processes, but there is much more to it. It is true that many diseases disproportionately affect Blacks and Latinos and those at a socioeconomic disadvantage. The most prevalent diseases that affect these two groups are diabetes, cardiovascular disease and hypertension, stroke, HIV and AIDS, asthma, and mental health. All three of these diseases are integrally related to one another. Diabetes can be the trigger for CVD, hypertension, and eventually stroke resulting from poor care of the others. Diabetes. Type 2 diabetes is a combination of factors: genetic, weight, and lifestyle. Many studies have shown that Latinos and Blacks have a genetic component to acquiring type 2 diabetes. Where the issue lies for this vulnerable population is the onset of type 2 is becoming earlier and earlier in life. This sets this population up for the comorbidities that tend to follow uncontrolled diabetes, such as renal disease, neuropathy, stroke, and MI, as well as many others. This population is less likely to live in healthy neighborhoods, many of which are listed as food deserts, and there is less ability to exercise. In relation to COVID-19, diabetes, especially uncontrolled, and obesity are risk factors for worsened outcomes and mortality. COVID-19 combined with a disease of the circulatory system that contributes to inflammation can be a recipe for death or lifelong complications. Cardiovascular disease and hypertension. 44% of Blacks, 45.7% of Black women, and 27% of Latinos have one or both of these. Blacks have higher mortality rates from hypertension related to conditions such as a myocardial infarction, congestive heart failure, and strokes. Stroke. Blacks are twice as likely to die from a stroke than whites. This is primarily because hypertension does not have symptoms until its later stages, or until the person does eventually have a stroke. Other health issues. HIV and AIDS. It has a disproportionate impact on racial and ethnic minorities. The CDC reports that in 2018, Black and Latinos accounted for 37,968 of the new HIV diagnoses in the U.S. Blacks and African Americans accounted for 42% of HIV diagnoses, and they are 13% of the population. Hispanic and Latinos accounted for 27% of HIV diagnoses and 18% of the population. This is because some population groups have higher rates of HIV in their communities, thus raising the risk of new infections with each sexual or injection drug use encounter. Additionally, a range of social, economic, and demographic factors such as stigma, discrimination, income, education, and geographic region affect people's risk for HIV. Asthma. There is a disproportionate amount of persons, especially children, who have asthma in these populations. Some of the reasons are pollution, cramped living, rental properties are not up to date, smoking, and secondhand smoke. Mental illness. Overall, this country lacks enough access to mental health resources for everyone. Latinos and Black men are disproportionately incarcerated, and many of them have underlying mental health issues that have never been addressed. Higher rates of HIV infection and higher incarceration rates among African Americans are further risk factors for COVID-19 infection. Systemic institutional bias throughout the criminal justice system has led to incarceration rates among African Americans in state prisons that is more than 5 times the rate of whites. Those who are incarcerated face an increased risk of contracting COVID-19 due to the difficulty of physically distancing under such conditions, among other factors. Health workforce and health system challenges. Inequities in the social determinants of health, such as poverty and healthcare access, affecting these groups, are interrelated and influence a wide range of health and quality of life outcomes and risks. Communities of color are also more likely than whites to report health care access barriers. Blacks and Hispanics are more likely than whites to report going without needed care due to cost. This population is more likely than whites to report no regular family doctor or PCP when sick, other than using the emergency room. The CDC and other resources have done extensive research into the challenges this population faces. Discrimination. Unfortunately, discrimination exists in systems meant to protect well-being of health. Examples of such systems include healthcare, housing, education, criminal justice, and finance. Discrimination, which includes racism, can lead to chronic and toxic stress and shapes social and economic factors that put some people from racial and ethnic minority groups at an increased risk of COVID-19. Healthcare access and utilization. People from minority groups are more likely to be uninsured than non-Hispanic whites. Healthcare access can also be limited for these groups by many other factors such as lack of transportation, child care, or the ability to take time off of work, communication and language barriers, cultural differences between patients and providers, and historical and current discrimination in healthcare systems. Some people from racial and ethnic minority groups may hesitate to seek care because they distrust the government and healthcare systems responsible for inequities in treatment, and historical events such as the Tuskegee study of untreated syphilis in the African American male and sterilization without people's permission. Occupation. Some racial and ethnic minority groups are disproportionately represented in essential work settings such as healthcare facilities, farms, factories, grocery stores, and public transportation. Some people who work in these settings have more chances to be exposed to the virus that causes COVID-19 due to several factors such as close contact with the public or other workers, not being able to work from home, and not having paid sick days. Educational, income, and wealth gaps. Inequities in access to high-quality education for minorities can lead to lower high school completion rates and barriers to college entrance. This may limit future job options and lead to lower paying or less stable jobs. People with limited job options have less flexibility. People in these situations cannot afford to miss work, even if they're sick, because they do not have enough money saved up for essential items like food and other important living needs. Fear of accessing healthcare facilities. Communities of color don't always have all the correct information when deciding to seek healthcare. In this pandemic, there is a lot of misinformation and lack of information that has prevented people from accessing care for COVID and other chronic conditions. Existing services and programs. I'm going to talk mainly about the programs locally in Pennsylvania. The disproportionate burden of COVID-19 infections and fatalities among minority groups in the United States should push policymakers, the healthcare community, and citizens to do more to rectify stark healthcare disparities, experts say. Since the country is full of resources related to COVID-19 right now, as I stated, I wanted to narrow my focus to the Lehigh Valley and the surrounding areas. It was surprising in the research that I conducted for this project that the two largest health networks in the Lehigh Valley region have not sufficiently addressed the larger disparities of minorities in relation to COVID-19. COVID testing access still remains limited to Blacks and Latinos as well as other populations. There are multiple sites located in downtown Allentown, Bethlehem, and Easton, as well as other areas with a large portion of Blacks and Latinos. There remains work to be done regarding access. Anyone who needs a test needs to contact a doctor in order to get tested. There are many barriers to this, such as technology and actually knowing where to go. The availability has become much better, but not where it needs to be. The turnaround times still remain over 48 hours for results in the eastern portion of Pennsylvania due to a shortage of reagents. Lehigh Valley Health Network Street Medicine team is trying to keep the homeless out of the ERs and away from COVID-19. Since the shelters were closed most of the beginning of the pandemic, it was more important than ever for the team to mobilize and to take to the streets. They are on the streets from 8 a.m. to 4 p.m. in the areas I mentioned before. For patients experiencing flu-like symptoms of COVID-19, street medicine provides them with a bus pass and a mask and referring them to the closest testing site. On a statewide level, Medicaid and CHIP. These are available in the state of Pennsylvania. Medicaid is only available to very low income. If a member of this population is working, most likely they do not qualify. CHIP is the children's portion of insurance in Pennsylvania and is available to all children in the state with a sliding scale payment system according to income. The SNAP Online Purchasing Program Pilot. As of May 18, 2020, the United States Department of Agriculture, Food, and Nutrition Services approved a state plan submitted by the Pennsylvania Department of Human Services for providing online purchasing options to Supplemental Nutrition Assistance Program households. The SNAP Online Purchasing Program allows Pennsylvanians to join the FNS pilot program for SNAP households to purchase groceries online through participating retailers. Online purchasing using SNAP is available at approved retailers as of June 4, 2020. Services and programs needed. The first would be expanded COVID-19 testing with complete follow-through for treatment. Second, insurance. Expand Medicaid to include the working poor. As stated above and in my practice, the working poor do not qualify for Medicaid as it stands now, but they can afford to purchase insurance on the markets. Mandatory sick leave. Many Blacks and Latinos work jobs that have no sick time. They go to work sick, unable to take time for illness, appointments, or even to quarantine. Legal and ethical issues. Medicaid coverage. The CARES Act, which was instituted during this pandemic, provides Medicaid coverage for COVID-19 related to testing and treatment. It has not addressed racial and ethnic disparities in access to health care. The health care provisions of the CARES Act does not cover many essential workers who are racial and ethnic minorities. Providing treatment fairly to the community goes along with allocating present and future supplies, treatments, and eventual vaccines. I have a question mark there because this is still up in the air as to how we're going to do this. African Americans and other minority populations are bearing the brunt of COVID-19. Bioethicists have looked at this. They feel as such they should have access to treatments and vaccines that will hopefully be developed for COVID-19 and policies that take into account that this should be developed in this regard. This will help rebuild trust and understanding within these communities. It may be important to focus on local and state health departments, federally qualified health centers, and other health care providers. Partner with community-based organizations that serve at-risk populations. This would help those without health care coverage, including undocumented immigrants, to seek care. Bioethicists have reported concerns relating to the direct threat the pandemic poses to overwhelm the capacity of scarce life-saving resources in acute care settings. Of primary concern is the possibility that shortages and subsequently rationing will occur, causing situations in which patients may be denied life-saving resources or having resources that were originally dedicated to a particular patient reallocated to another patient. Despite broad recognition and agreement that allocation strategies should include the voices of the minority communities, bioethicists have either been involved in developing plans or have endorsed allocation plans in which there is no evidence that minority voices have contributed to those plans. When some bioethicists have publicly raised the question about involving minority populations in the development of various allocation plans or strategies, these voices tend to be silenced by those who insist allocation decisions, such as those expected with COVID-19, are simply clinical in nature. Nursing interventions and strategies. There are so many messages about COVID-19 circulating the internet and other media. It is hard for some people to know what they should be doing or not doing. This is especially true in the minority population. So nurse practitioners need to collaborate with other healthcare providers to ensure the safety messages related to COVID-19 are consistent, clear, and concise. The nurse practitioner's job when meeting with patients in this population is to present that clear, concise, correct information to the patient in a language or format that best suits the person's education level. We need to emphasize the importance of coordination and key messaging between health, education, and various other sectors when planning and implementing effective pandemic responses. As leaders in health promotion, we need strategies to communicate important health messages in a concise and meaningful way that makes it easy and accessible for patients to understand, navigate, and take action. We also need to be careful how we convey content through electronic communication channels and consider an appropriate level of frequency of such communication to achieve optimal impact. Without doing so, there is a potential to reinforce community ambivalence at one end of the spectrum and create panic at the other. Develop and provide training for healthcare professionals on cultural differences and barriers Blacks and Latinos have to improve overall health. Developing a training program and delivering it would be an enormous process that would begin with my own self-assessment of my knowledge and biases. The reason developing a program would be advantageous to take on as a medical professional and a nurse is that in developing such a program, We learn in the process. Cultural competence is a process rather than an ultimate goal, and often developed in stages by building upon previous knowledge and experience. No one is culturally competent after one session or an entire semester of training. This is a learning process that has to then be put into action. In researching this intervention, there is very little concrete evidence of the best way to evaluate the outcomes of training. Monitoring and evaluating patient-centered care for ethno-cultural communities would allow for the improvements to be made in the delivery of culturally competent health care. Mandatory paid sick time for all part-time and full-time workers in the state of Pennsylvania with no penalties. I would advocate for a mandatory paid sick time. Only a handful of states require private businesses to pay sick leave. Many people in this population do not have paid sick leave to stay home sick or to go to needed doctor's appointments or, as I stated earlier, to quarantine. Taking care of ourselves is part of staying healthy. Black and Hispanics may just be making ends meet, and to have to take a day without pay is not a possibility. This would have to begin with research into advocacy, planning, and implementation of this in other states similar to Pennsylvania, contacting those legislators in other states or professionals who have been successful in pushing this legislation through, research whether or not Pennsylvania has tried to pass this before and what roadblocks may have been discovered, contacting legislators in our state of Pennsylvania, probably numerous times, presenting my research to those who would be interested, especially regarding the populations that this will help. The measurement of success would be whether or not we could get this to vote. This would be a very long process, but it would be worth it. So my conclusion. Much has been discovered in the recent months that COVID-19 has become the bellwether regarding health disparities. These disparities have always existed, and one powerful infectious disease pandemic has put them in the spotlight. The aftershocks of COVID-19 pandemic may be seen for generations. We can already see how the pandemic is changing health practice and clinical delivery. Hopefully, it will also shift the social landscape as well. We need to act now on these disparities because when the dust settles from this pandemic, will we once again have amnesia about these issues? As a society, we need to remember who diseases affect disproportionately and why. Take a 30-second pause, close your eyes, and put yourself or your parents or your loved ones in the shoes of someone of this population, knowing what you know now. And how would you feel internally about this? These are my references. And I thank you for listening to my presentation today. I hope you learned something. And if you ever have any questions, you can contact me at the email below, and I'd be glad to get back to you. Thank you very much.